Ozempic, whose active ingredient is semaglutide, can lower A1C before the scale looks impressive. That lab number is your longer-term blood sugar marker, not your weight loss score. Early progress can come from calmer after-meal sugar spikes, less sugar released by the liver, and a better insulin response. So if the number improves first, that may be real progress. The scale may catch up later too. Many people judge Ozempic by the bathroom scale. They start the medicine, wait 2 or 3 weeks, and expect weight loss to prove success. But for type 2 diabetes, blood sugar control can change while the mirror looks the same. That mismatch can make a working treatment look disappointing. The better frame is simple. Ozempic is a diabetes medicine that also affects appetite and weight. One patient may lose pounds quickly. Another may show better glucose readings with little visible body change. Before judging either response, name the target: diabetes control, weight reduction, medication safety, or all three. I'm Dr. Kim, a licensed physician. This is not medical advice. Consult your doctor. The A1C test estimates average blood sugar over about 2 to 3 months. It is not the same as a fingerstick glucose reading. A fingerstick shows one moment. The A1C test shows a longer view, although recent weeks can still affect it. There is one testing trap before you trust the number too much. The test depends on red blood cells, the cells that carry oxygen. Anemia means too few healthy red blood cells. Kidney disease, bleeding, transfusion, pregnancy, or some blood conditions can make the result less reliable. That is why one number needs context. Compare it with fasting glucose, after meal readings, thirst, urination, energy, and appetite. If home readings disagree with the clinic test, say that clearly. The goal is to know whether the change reflects real control or a misleading signal. Once the result is placed in context, the timing makes sense. If daily glucose spikes shrink, the average can start falling before clothing size changes. The test is reacting to sugar patterns, not waiting for genes to fit differently. That flips the usual assumption. Weight loss is not the only route to better blood sugar. Ozempic can affect glucose pathways directly. Appetite change may help, but it is not the whole explanation. One route is insulin. Insulin is the hormone that helps move sugar from blood into cells. Ozempic can help the pancreas release insulin when glucose is high. That timing matters because the response follows the blood sugar signal. Another route is glucagon. Glucagon is a hormone that tells the liver to release stored sugar. In type 2 diabetes, that signal may be too strong overnight or between meals. Ozempic can lower that signal, so morning readings may look calmer. A third route is stomach emptying. Food may leave the stomach more slowly, so meal sugar enters the blood more gradually. That can reduce sharp after-meal spikes, especially after larger meals. This effect can be strongest near the beginning and may fade later. The risk hidden inside this early win is simple. The glucose reading may look cleaner while the person is not functioning better. Appetite may be too low, they may eat too little, or older diabetes medicines may now be too strong. So the number can improve while the plan becomes less safe. That risk creates two different stories. In one story, glucose falls and daily energy stays steady. In the other story, glucose falls, but the patient feels weak, nauseated, dizzy, or unsafe. Same direction on paper, different meaning in real life. The starting glucose problem helps explain which story you are seeing. Large dinner spikes may improve after smaller evening portions. High morning readings may improve when the liver releases less sugar overnight. Different starting problems can create different signals. The timeline connects that story to the visit. Put morning readings, after-meal readings, dose dates, appetite changes, and warning signs on one page. This shows whether the change was steady, sudden, helpful, or linked to a new problem. The key decision is whether the benefit stayed safe. A good response means glucose improves and daily function holds. A trade-off means the number improves, but eating, hydration, energy, or safety gets worse. That distinction matters more than which number changed first. The safest interpretation comes from direction, timing, and how the person feels. Direction shows whether readings are drifting better or worse. Timing shows whether the change followed a dose, meal, or missed medicine. How the person feels shows whether the result is usable at home. Averages can still mislead. A week with one low reading and several high readings may produce a number that looks acceptable. The average hides danger at both ends. Write down timing, how you felt, and the reading itself. One useful question is whether steadier numbers came from steadier routines or from accidentally eating far less than needed. If meals nearly disappear, the same number can feel worse, not better. That difference helps separate real control from strain. Meal size matters when readings jump after dinner. A smaller evening meal can help the next morning, but skipping food can backfire. The goal is steady portions, not punishment, especially when appetite is already low. After food amount is checked, medicines are the other side of safety. Risk rises when Ozempic is combined with insulin or sulfonylureas. Sulfonylureas are older diabetes pills that push insulin release. Repeated shaking, sweating, sudden hunger, confusion, or weakness should be discussed as warning clues. Stomach problems need their own label. Nausea may follow dose changes or stomach slowing. Shaking or confusion belongs with low glucose signs, not stomach side effects. Clear labels help the clinician choose the next step without using one fix for every problem. After the main problem is labeled, check what else changed that week. A skipped meal, a late dinner, alcohol, missed doses, or a recent illness can all shift glucose. Mark the injection day, missed medication, and warning signs. This makes the visit more specific and less dependent on memory. Vomiting, diarrhea, or not drinking enough can also shift the reading. Dry mouth, dark urine, or dizziness should be mentioned with the glucose log. This matters because dehydration can make dizziness, weakness, and constipation feel worse. Call your clinician sooner for repeated low glucose, confusion, fainting, severe abdominal pain, repeated vomiting, or dehydration. These signs change the meaning of early success. A lower reading is not useful if the patient cannot eat, drink, think clearly, or function safely. Do not change diabetes medicines on your own. Review readings, side effects, appetite, dehydration signs, and dose timing with your clinician. This is especially important when insulin or older diabetes pills are part of the plan. A safer change starts with the log, not a guess. After urgent problems are addressed, durability matters. Regular eating, steady sleep, and light movement help keep the improvement stable. If the daily routine collapses, the benefit may fade. For weight goals, watch waist size, bowel pattern, appetite, and food quality. Early weight may stay flat while glucose improves. Mild problems may allow patience, but warning signs need medical review. Success should not be treated like a trophy number. If your A1C improves before weight changes, call it a clue, not failure. Ozempic may be helping glucose first, but the plan still has to last safely in daily life. Medicine simplified. That's what this channel does. If you want more, hit subscribe. This is not medical advice. Consult your doctor.